In this journey of international research training program, we come to the part 2 of congenital rickets discussion. And the first question comes from Jordi.
What are the features of congenital rickets?
In the previous episode, we spoke about the clinical features of congenital rickets like poor growth, and baby can have fractures while inside the uterus, or she may or he may develop some deformities, and as the birth takes place, you may notice the anterior fontanelle which is wide open and some complications regarding it. We have seen about craniotapes, occipital flattening, frontal bossing, and teeth, delayed eruption, enamel hypoplasia, and probability of caries, pectus carinatus, rachitic rosary, Harrison's groove, bone pains, widened epiphysis, muscle weakness causing protuberant abdomen, hypotonia. There is delay, regression of gross motor skills reflected in the milestones which are delayed, and we clearly observe the delayed motor skills of the baby. Metaphyseal cupping, bowing if weight bearing. So the clinical picture can vary from intrauterine growth retardation, stillbirth, or preterm deliveries. So premature development causing a lot of respiratory problems, deficiency of the development of the brain functions, neurological functions. All these can be seen, or later they can develop slowly.
Please remember, absence of clinical signs of rickets does not exclude rickets. Hence, we have to be very careful, especially in the early stages, to have an element of high suspicion, carefully exclude with observation and evaluation. If required, blood tests and other things.
So doctor, where is the site of the bone most involved?
The baby who crawls and the baby later who walks. Baby who's crawling. So where is the weight going? Into the upper limbs. So where will the deformities occur in a growing infant or a small toddler? You will have the wrist deformities occurring. The rachitic cuff, CUFF. Why? Due to the epiphyseal growth plate that has been really stretched layer by layer in the hypertrophic zone, which is not getting mineralized. Due to weight bearing, they start bending. And you have other features, radiological features are several. Okay, so this is how. And later you will have the lower limbs that get involved. One more answer. Radius and ulna, I have read that the ulna gets deformed more. Why? Because it grows faster than the radius. Repeat? I will repeat. Ulnar bone grows faster than the radius, hence ulnar pain will be more, deformity will be more. That too where? On the outer side or inner side, the anatomical position on the radial or the lateral aspects of the ulna, you will have more changes. How to suspect a baby, newborn baby, whether it's congenital rickets or nutritional rickets? There are certain things like family history of skeletal deformities, 1. 2. Stunted growth. 3. Alopecia, hair is not there. Dental anomalies, delayed eruption or enamel hypoplasia predisposing to dental caries are all pointers to genetic causes. And parental consanguinity, closed marriages, also they have more instances of congenital rickets.
What is the wavelength of ultraviolet radiation that can be helpful when it comes to synthesizing vitamin D?
To answer this question, UV light which falls on the skin is of type B, okay, and the wavelength is between 290 and 320 nanometers that is required. Anything above or below doesn't work, and A type of wavelength doesn't work. It's your entrance bit. It is your short notes. Okay. Now we are going into rickets classification by Sagarika, who has done an excellent job. Let's hear her.
So now let us see the types of rickets. First we have calcipenic rickets. This occurs due to insufficiency of calcium due to dietary sources. It can also occur due to vitamin D deficiency. Next we have phosphenic rickets. It occurs due to low phosphate levels due to impaired absorption of phosphate in the intestines. Now we have vitamin D dependent rickets. These are of type 1, 2 and 3. So now we know how vitamin D is activated. From the skin, it is converted into 7-dehydroxycholesterol to vitamin D using UV rays. This vitamin D then goes to the liver, where it is converted into 25-hydroxy vitamin D by an enzyme known as 25-hydroxylase. There are certain receptors on the liver which help in this process. So such a receptor is CYP2R1. If there is a mutation in this receptor, it does not allow the conversion of vitamin D into 25-hydroxy vitamin D. This causes vitamin D dependent ricket type 1B. So now next, this 25-hydroxy vitamin D goes to the kidney to transform into 1,25-hydroxy vitamin D, which is the active form of vitamin D. If there is a mutation in the receptor in the kidney, then that does not allow the transformation of vitamin D into active vitamin D. This causes vitamin D dependent rickets type 1A. Now we also have vitamin D dependent type rickets 2. In 2A, vitamin D dependent type 2 rickets A, we have vitamin D receptor gene mutation. Actually, vitamin D receptors help in the proper utilization of vitamin D in the bodies. A mutation in this gene causes resistance to vitamin D in our body. Vitamin D dependent rickets type 2B occurs due to overexpression of a nuclear protein that interferes with the normal function of vitamin D.
Hello, sir. I have a question for you. What are the types of phosphatemic rickets?
Shabir asked a very good question about congenital phosphatemic rickets. Now, phosphatemic rickets, which is congenital, can be again divided into two types. One is FGF23 dependent rickets, FGF independent rickets. What is dependent? They have a phosphatonin, okay, which helps in the mechanism, and it is independent. Phosphatonin has no role in the FGF independent phosphatemic rickets. Stop, pause, learn about it, move ahead. 15 minutes, we cannot say everything. 15 minutes must make you read for 4 days. Now coming to FGF, fibroblast growth factor 23 dependent rickets. We have three varieties: X-linked, second is dominant, autosomal dominant, third is autosomal recessive. So what happens in this FGF dependent? There is a mutation or some abnormality in the phosphatonin. The abnormality that is occurring in the phosphatonin causes these kind of problems, and they can be classified as, again to repeat, X-linked, autosomal dominant, autosomal recessive. Interesting, isn't it? Now when we are talking about a patient with FGF independent rickets, how do you say it's independent? The FGF levels are normal in the blood. FGF 23 levels are normal, but still the patient is developing rickets, congenital rickets, and you have ruled out everything else. Maybe it is a case of FGF independent rickets. So in this FGF independent rickets, it is mostly the FGF 23 levels are normal. There is renal tubular defects of the co-transporters. That's what has to be remembered.
So let's say there's a patient that has high normal serum calcium as well as normal serum phosphate, but for some reason the mineralization is inhibited. So what could be the reasons due to this mineralization? That's my first question for Dr. Kiran.
This is a very good question. Can calcium and phosphate be normal? Calcium is normal, phosphate is normal, but mineralization is not there or inhibited or decreased, causing rickets.
In this scenario, we can have hereditary hypophosphatasia, medications, toxicities.
In premature infants, the bodily functions are not prepared as much as a normal infant who is delivered normally or cesarean wise. Now they cannot sustain because the bones are already weak. How? Low phosphate. How? There are two ways. There are two mechanisms by which phosphate can become low. One is FGF23. FGF23, or the fibroblast growth factor 23, causes more loss of phosphate in the urine. So it is getting depleted. Also the absorption is also decreased. This is the function of FGF23. If there is any condition which increases the FGF23 production or delay or decrease in its degradation, FGF23 levels increase and cause extensive loss of phosphate in the urine, and also reabsorption is lost, so hypophosphatemia is the result. Next reason is certain mutations that take place which cause the sodium dependent phosphate co-transporters. Like I gave you the example, baggage handler is not there, so belt is empty for a long time unless one more person goes. That could be our medication. In the future, genetic engineering, we never know, this baggage handler. So here what happens again, there is somebody is not carrying the baggage, the phosphate into the blood. So there is loss of phosphate in the urine, causing hypophosphatemia and causing bones are weak, osteopenia, rickets ensue. So phosphate related, so many things, two causes, main causes, FGF23 and the co-transporters are deficient.
My next question is that what are the other differential diagnoses that you can find out for a patient that has rickets, and how do you come about as to which one is the final diagnosis?
So when we are talking about nutritional rickets and other things, we have to also take into consideration in children if rickets is developing with malabsorption. In celiac disease, cystic fibrosis and other conditions of malabsorption, rickets can develop in a child. So this element of suspicion must be kept in our mind always.
Sir, can rickets and osteomalacia coexist in children?
Yes, they can exist. Otherwise, how are they bending? Unless there is softening of the bones, how are they bending? We do see pseudo fractures.
Why is phosphate deficiency not that common?
No. Why? Most of our foods contain phosphate. So to get phosphate induced rickets is little uncommon. Anything can happen in between. There are so many scenarios, but it's uncommon.
So what type of vitamin D is tested routinely?
Routine testing of vitamin D, 25-hydroxy D3 is tested because it is stable.
One more question. When is 125-dihydroxycholecalciferol vitamin D3 tested in the blood?
See, the calcitriol test 125-dihydroxy D3, the active form, has to be tested whenever you have a suspicion. Adequate level is 30 to 50 nanograms per ml. If it is more than 50, it is high. Less than 20, it is low. So we have to understand when we have to do this calcitriol test. Vitamin D deficiency or insufficiency, abnormal calcium levels, very high calcium levels, some parathyroid disorders, rickets of a little confusing picture, genetic predisposition to vitamin D deficiency, and most important, whenever they have a kidney or chronic renal failure or renal osteodystrophy, that is a time when calcitriol must be tested without fail. Now let me invite Ajin Matthews, final year medico from Tbilisi State Medical University, to explain to us the treatment of genetic rickets.
So in the case of genetic rickets, treatment focuses on correcting the mineral imbalance and supporting bone health. For X-linked hypophosphatic rickets, patients typically receive phosphate supplements and active vitamin D, which is calcitriol, while newer treatments like burosumab target the underlying cause. So in vitamin D dependent rickets, that is VDDR type 1 and 2, patients require high doses of calcitriol and in some cases calcium supplements. Regular monitoring is crucial to prevent complications, and orthopedic treatment may be needed for severe bone deformities. And genetic counseling is also recommended for the affected families.
So as a part of the clinical features, let's have for completion one thing. Like I told you, you have to have an element of suspicion when the baby is constantly in pain. They may be asymptomatic, but they can extend into irritability. There may be growth retardation. We have to keep watching the baby. Suddenly something, sudden death. We spoke about SUDIC. Sudden death can be seen. So to avoid long-term complications, rickets must be promptly diagnosed with a suspicion and aggressively treated. That is the most important point. Don't let the orthopedic surgeon come into the scene to correct or osteotomy, break the bone, or do any splinting, or do whatever orthopedic point of view. It should not reach that stage, hopefully. And nutritional rickets usually recovers very nicely. Genetic rickets, yes, you know, I know, it's very difficult to treat. Maybe surgery is required.